And this is a symposium about new technology. My colleagues are going to be presenting two brand new pieces of technology to you, which are both very exciting, completely different, but linked to this theme of patient blood management. So we're just going to introduce the talks by talking to you a little bit about patient blood management. And of course, this is something we should be doing very routinely. So my name is Andrew Klein. I come from Cambridge in the UK. And I have a number of conflicts of interest from various companies that have paid for various studies that we're doing that I've listed here. And patient blood management is something that really is compulsory and should be part of our routine practice. So really, I'm not here to teach you about patient blood management. We're here to teach you about two new pieces of technology. But I'm just going to show you that this should be embedded in our practice. This is compulsory. It's even the law in Italy. So in Italy, patient blood management is the law, and Italian hospitals have to follow this as part of their legal jurisdictions. It's not the law anywhere else in Europe, but it's recommended in just about every guideline and protocol throughout Europe and indeed throughout the world. And I'm going to give you some examples of some of these guidelines. Some countries are still developing their own national guidelines, but we've got national guidelines in the United Kingdom. There are European guidelines, Australian guidelines, US guidelines. They're very advanced in Australia, where they have patient blood management as a master's level diploma, where you can take individual components of patient blood management as part of their a master's level sort of certification. So they're probably most advanced in Australia, but certainly very advanced in the US, and as I said, throughout Europe. And these are the European guidelines. And you can see that the two technologies we're going to talk about today, I've highlighted in yellow for you. So the first talk is going to be about cell salvage. And cell salvage appears again and again and again throughout every guideline. And then the second talk we're going to talk about is point of care management, or algorithm targeted perioperative coagulation therapy. And again, that's very much throughout every single guideline throughout the world. So these are really important focuses for all our guidelines on patient blood management. And this is the ESA. So the other one was the cardiac one. This is the ESA one. So you can see cell salvage appears there, and patients with comorbidities, so hemostatic derangement and measuring, appears there. And this is the ESA one. They decided it was level 1B for a level of evidence 1B. So randomized controlled trials, but not meta-analyses yet, looking at the benefits of point of care testing during in patients who are bleeding. And this is the Italian law. And you can see hemostasis and coagulation management is there. And this is the Association of Anaesthetists one in the UK, which we're just updating this year, so there'll be new ones coming out in 2023. So in the UK, point of care testing and cell salvage is there as well, very much as the focus. This one is the American ones for the ASA, and you can see again point of care testing and cell salvage. And these are the Australian version of it. And you can see there's this whole module, which is their module 2 in their master's level certification. And there again, hemostasis and intraoperative cell salvage. So this is the relevance of the two technologies we're going to talk about. And this is perhaps the best summary, looking at point of care testing, which were the British Haematology Society guidelines, where they list the levels of evidence for each of the different specialties, so cardiac, obstetrics, and they look at point of care testing within each of those specialties. And I've put up the cardiac ones here for you, and you can see the evidence is not fantastic yet. There haven't been really fantastic level 1 trials, so they've said level 2 level of evidence, but it's still pretty consistent throughout the guidelines. And in our practice, we use exclusively point of care testing. We don't bother with laboratory testing anymore for hemostasis. We just use point of care testing. Our laboratory is now miles away, and it requires a porter to do a 40-minute run along a road, down a corridor, crossing a road, take a blood sample, and then it requires it's about a 3-hour wait. So now with our Rotem, it takes us 10 minutes. So we've abandoned doing laboratory testing, and we just use point of care testing. And you can see, looking at the sort of the level of evidence, it's mostly level 2. So really there's a need for a big, RCT in point of care testing. And then as far as cell salvage go, these are perhaps the best guidelines. I can say that because I wrote them, so that's fine. So these are perhaps the best guidelines for cell salvage that come from the UK, where we concentrated specifically on cell salvage. And again, the evidence is not amazing. There's not been really big multi-center level 1 evidence trials. There's been single center randomized controlled trials in cell salvage. And consistently, they've shown a benefit in terms of reduction in blood transfusion. But what's interesting is, I was just chatting with my colleague who's coming up next, is that France have just received a grant for a multi-center randomized controlled trial in lots of patients looking at different cell savers, so testing out the technology in a big multi-center trial. So that's very exciting. So maybe we'll be able to go from level 2 evidence to level 1 evidence now that there's big trials going on. So I hope I've shown you that this really should be at the forefront of our thinking in terms of what we do as cardiac and thoracic and vascular anaesthetists, and also in our ICU practice we use both points of care and cell salvage. So I'm going to hand over to my colleagues who are going to present to you 2 really very interesting and exciting new technological advances. Thank you very much.
Hello everyone. My name is Alexandre Mansour. I'm a French anesthesiologist and intensivist. I'm working in City ICU in Brittany, in Rennes University Hospital. I want to thank the i-SEP and the HemoSonics company for setting up this symposium and for the kind introduction. So we'll talk about cell salvage. I have a few conflicts of interest, especially regarding my position as consultant and primary investigators for clinical study for the i-SEP company. The topic of cell salvage is often limited to guidelines like this one, really good ones, European, American, French, of course, guidelines that recommend the use of cell salvage during cardiac surgery. But we often limit the presentation of cell salvage like this, and the cell salvage is often seen as like a black box in cardiac surgery, and it's done either by the anesthesiologist, the nurse anesthetist, the surgeon, the perfusionist, but we don't really know how it works, how it is validated on a biological or clinical level. So before digging deeper into the new technology that I'll present to you, we'll talk a bit about how the technology works. I think you all know current commercially available centrifugation-based devices. Those devices, as you know, all rely on the principle of suctioning the blood from the operating field, surgical field, and they all are based on a centrifugation process using a Latham ball. And by doing this, they produces a waste bag containing platelets, leukocyte, plasma proteins, and fractionated heparin, free hemoglobin, and they are concentrating red blood cells. So, of course, the biological evaluation of these devices is based on either the washing performance in terms of removal ratios of unfractionated heparin, cytokines, plasma, coagulation factors, and so on, and also leukocytes and platelets, and for the recovery performance in terms of red blood cell concentration, post-treatment hematocrit, post-treatment red blood cell count. And these devices all perform well in terms of concentrating red blood cells, obtaining hematocrit from 50 to 60%, and they all perform well in terms also of washing performance with high quality of unfractionated heparin washing, free hemoglobin washing. In terms of just a little point on free hemoglobin, why it is recommended to wash free hemoglobin. It's not based on a high quality level, but on a suspicion of increased risk of renal kidney insufficiency. And so the AABB guidelines recommend a threshold, maximal threshold for allogenic products and cell salvage products. It's also an important point, leukocytes. How many of you know how many leukocytes are recovered by your centrifugation-based devices. If we'll listen to the company, mostly none of leukocytes, but if we look at the result from the literature, you can see that all your devices that you're using on daily basis, they recover leukocytes, 50 to 80% of leukocytes, and these leukocytes were not evaluated in well-performed studies, translational studies. We don't know if they are activated. We don't know if they are apoptotic leukocytes. And of course, there's need for clinical evaluation in terms of both benefits and risk, in terms of bleeding, in terms of allogenic product transfusion, blood products, and of course, morbidity and mortality. If we sum up the current literature, as Professor Klein just did, the use of cell salvage in cardiac surgery may decrease allogenic red blood cell transfusion in cardiac surgery, mostly in high-risk cardiac surgery, and probably as a small or no impact in now a small lower risk surgery. And this without increasing blood product use, without modifying postoperative outcomes, except for reducing cognitive dysfunction in a old now RCT. So there is a need, as just said Professor Klein, there is a need for high quality, randomized, large scale studies in cell salvage. Now we'll talk about more new technologies. Platelets, you know very well that they are important in hemostasis. We know that thrombocytopenia, we know that platelet function defect or bleeding risk. But on the other hand, the transfusion of allogenic platelets have demonstrated no benefits to date in randomized controlled trials. There are no evidence. And there are conflicting results of potential risk associated with allogenic platelet transfusion. And so the i-SEP company, that is a French company based in Nantes in France, developed a new auto-transfusion device that you can see here at the Congress, that is based not on a centrifugation process, but on a filtration process, and it combined filtration and washing. And so instead of the centrifugation bowl, there is now a hollow fiber filter cartridge that is able to filter the blood suction from the surgical field and to produce a waste bag with this time plasma protein, free hemoglobin, cytokines, and fractionated heparin. But this time in the concentrate, you'll see red blood cell, but also platelets and leukocytes. So all cellular elements. We had the chance 2 years ago to publish the first preclinical result of the device in anesthesiology using human whole blood in ex vivo study. And we demonstrate for the first time that this device was able to recover and wash red blood cells like any other cell salvage with high performance, but also to recover platelets. At this time, in the ex vivo study, we recovered 37% of platelets, and we demonstrated that the platelets were not activated by the device using flow cytometry. We also perform cytometric analysis of leukocytes, and it's the first time that leukocytes are really evaluated in a cell salvage device, and the device does not activate leukocytes. The leukocytes remain functional in cytometric analysis. 2 years later, we had the chance also to publish the first clinical result of the device, a first-in-man study, non-comparative in cardiac surgery. You'll see now in the slides sometimes QR code. Don't hesitate to scan the QR codes to obtain the full paper of the device. And in this device, including 50 patients in cardiac surgery, mainly moderate risk bleeding cardiac surgery, CABG, valve surgery, aortic root surgery, simple aortic root surgery, we were able to demonstrate that the device processed very well red blood cells, has a high washing capacity like any other cell salvage, with somewhat a lower hematocrit of 42%. But the main innovative result lies in its capacity of platelet recovery, with 52% of platelet recovery, which is, like you can see, way higher than current centrifugation-based devices. In this study, we perform biological analysis of platelets in the blood from the device, not on the patient, but on the device, before and after the treatment process. And we use flow cytometric analysis of platelet glycoproteins. And as you can see in blue bars, the device before and after the first and second cycle of treatment did not, or really in a limited fashion, activate the platelets. And as you can see in the green bars, when we're using thrombin stimulation on the platelet ex vivo, we are adding trap stimulation for exhibiting a platelet activation using the thrombin activation pathway. You can see that before and after the treatment, we can still activate platelets in vitro. So now we're moving, as Professor Klein just said, to the next step, which will be at the beginning of 2024, the beginning of a new RCT in cell salvage, French RCT, including 10 centers, large standard tertiary centers with high volume of patients, randomizing i-SEP technology versus centrifugation-based technology will include more than 500 patients, high bleeding risk surgery patients, with a primary outcome based on the UDPB score. And also, the device obtained the CE marking last year and is now commercially available. And so the i-SEP company, with an academic support of the French Association for Cardiothoracic Anesthesia and Intensive Care, the ARCOTEVA, set up a post-market registry, the SEPIA registry, that will include all patients in the centers that are doing cell salvage using the i-SEP technology, and that will include both i-SEP technology and centrifugation-based devices, as most of these centers use both i-SEP and centrifugation technology. So, as for our personal experience in Rennes, we have a university hospital with a high volume centers and a large experience of cardiac surgery and mechanical circulatory support. And we're using the device since last July, a bit more than 3 months of experience with more than 50 patients. We are finishing the learning curve for all our practitioners and nurses, and so we'll begin soon translational studies, biological studies in a real setting, and this device is included in our patient blood management strategies and protocols that is using also, as we'll hear in the next presentation, viscoelastometric testing using Contra. So I hope now you can get rid of this black box effect and you know more about cell salvage. And I think we now need to consider cell salvage not as a black box, but as perfectly integrated in patient blood management protocol, which is truly important that it needs to be multidisciplinary, using nurse anesthetist, anesthesiologist, intensivist, surgeons, perfusionist, and taking into account the kind of the type of surgery, the type of management of cardiopulmonary bypass. Thank you for your attention. If you want to know more about the device, about platelet autotransfusion, you can scan this QR code for the paper, for a podcast of the American Society of Anesthesiology, and for a webinar of NATA. Thank you for your attention.
Well, good afternoon. My name is Alex Barroso and I come from Andalusia, Spain. First of all, I would like to thank Dr. Nathan Olsen and Carmen Martinez for helping me with this presentation. This presentation is titled Implementation of a Novel and Faster Point-of-Care Hemostasis Analysis. A bit of my background: I work in the Malaga Hospital and I also teach at Malaga University. But before, I've been working in King's College London and Imperial College. These are my disclosures. Well, the learning objectives of this talk could be briefly describe how a comprehensive patient blood management approach keeps focus on the patient, lightly touch about or lightly talk about the evolution of bleeding management with patient blood management and with viscoelastic tests, and then focus on the implementation of Quantra-based algorithm in patient blood management, sharing some of our experience. The reason of this talk should be clear at this point of the presentation after the talk of my two colleagues. So just say that every effort should be made to avoid allogenic blood transfusions. Cardiac surgery, but also liver surgery, liver transplant surgery are complex and high-risk procedures that often requires the use of blood products to replace the blood loss and to support the patient cardiovascular system. However, blood transfusions are not without risk, and as you know, including transfusion reaction, infection, and immunological reaction. That's why a transfusion means not only reduce the transfusions, means not only the reduce morbidity and mortality, but also costs. As Andrew said, the use of viscoelastic testing devices now devices as part of a goal-directed treatment approach to manage perioperative bleeding has been recommended now by several international organizations and clinical guidelines, such as the ASIA, the STS, or the European guidelines. Obviously, we cannot talk about viscoelastic testing without talking about ROTEM and TEC. These two technologies emerge at the forefront of the whole blood viscoelastic testing. Both use the adaptation of the classic methodology that involves a pin suspended in a cap containing a blood sample. Studies like this one in Spain shows how still today most of the centers use these two devices. However, 4 to 5 years ago, because several reasons, because several issues in our hospital, we changed to a new generation viscoelastic test device. This is the Quantra system, which is a cartridge-based viscoelastic test system that uses a novel ultrasound technology that facilitates the use of point-of-care hemostasis analysis, allowing a quick and reliable clinical results. During the past few years, evidence has started growing up supporting the use of this device and the new technology. Before talking and before sharing our experience, I would like to introduce my hospital, which is a hospital of 1,100 beds, we have 82 beds for critical care patients. We usually do 300 open heart surgeries per year and around 60 liver transplantation per year. And as we said about the protocols, clinical guidelines developed by different societies for patient blood management recommend the use of viscoelastic testing devices in conjunction with goal-directed treatment algorithm to aid in the management of coagulopathic bleeding. As Andrew mentioned before, the recommendations are Class 1 recommendation, Level 2, and the evidence is starting growing up. This could be the protocol that we use in cardiac surgery in our hospital. We use a baseline test that is going to give us an idea of the baseline of the patient, and then we do on surgery, while the surgery, and after Quantra sampling after the protamine, after the bypass, depending on in the surgical situation, the clinical situation, if it's bleeding, if it's not, and the previous Quantra results, we do future sampling. But you are gonna see it clear with some examples that we are gonna go through. This, for all of you that you are not familiar with the monitor, this is the main display, the main screen that we will see. On the top part, we are gonna see an assessment of the clot formation and of the onset of the clot formation for the dials for the clotting time ratio, and clotting time with heparinase, because this cartridge got heparinase, not the one that we are going to use later on. I'm going to show you for liver transplant. And at the bottom part, what we are going to see is the assessment of the clot stiffness with the contribution of the platelets and the contribution of the fibrinogen. This is the the treatment goal algorithm that we use in our hospital. There are several, but this is the one that we use for cardiac surgery. And as I said, we are gonna see it, how it works clear with an example. But briefly, we assess for the onset of the clot formation, and depending on the result, the algorithm will suggest us to put some treatment on. This treatment should be protamine or FFP, PCC, depending on the abnormal results of the Quantra. Same happen with the clot stiffness. But we are going to see it through a clinical case, a real clinical case. This is a 79-year-old male with severe aortic insufficiency, mitral insufficiency, severe pulmonary hypertension, and a depressed left ventricular function that was programmed for a double valve replacement with a tricuspid annuloplasty and a pacemaker implant. This image here is the display of the first test, the baseline test. As you see, all arrows are at the green bit of the dials, meaning that everything was under control. So we started from a good place. But during surgery and after the bypass, a long bypass, we found a clinical situation where we found a clinical relevant bleeding with poor surgical control. What the Quantra said? The Quantra said that beyond the assessment, there were abnormal results for the onset of the clot, as the CT was prolonged and the CTH was prolonged. It wasn't due to the heparin. As we see, the CTR was normal. That correlates very well with the ACT. In this case, the clot stiffness was fine. But it is important to get the whole set of results. It only took 13 minutes, which is, in my opinion, much quicker than other devices. So following the treatment algorithm, we treat that patient with FFP to treat the clotting time, and obviously the bleeding with some blood. So the bleeding was controlled, the surgery could be finished, and the patient transferred to the ICU. What happened at the ICU? So in the ICU, within the first 2 hours, the patient got much worse, and we saw that the bleeding through the chest tube around 900. Obviously, this patient got an early prosthetic dysfunction diagnosed by echo and require reoperation. At the meantime, we did another contrast. And what is said? Again, the clotting time was elevated. It wasn't due to heparin, and now the clot stiffness was low, probably due to PCS, but also fibrinogen. The PCS due to platelets, to the platelet contribution. We were facing now a cardiopulmonary bypass associated coagulopathy. How we treat it? Following the goal-directed treatment algorithm that we saw before, with obviously blood for the bleeding and FFP, platelets, and fibrinogen. During the reintervention, we did now a pump of 63 minutes, but the patient after the pump continued coagulopathic. It was bleeding. The Quantra results at the Quantra test at that time showed again a clotting time elevated and a clot stiffness diminished. We follow again the algorithm, the treatment algorithm using FFP, PCC. At that time, we needed to add something else, and platelets. So bleeding was controlled and transferred to the ICU for post-operative control. After a few hours at the ICU, the patient was stable and there was no bleeding. That was the Quantra results after a few hours at the ICU, where no coagulopathy seems to be. As you saw, it was very easy to follow each of these steps. So this is one of the main reasons why we adopt and continue using this technology. A very similar environment in terms of complexity and risk we can find in liver transplant. We have also protocolized the sampling, to take the samples during each one of the main phases of the liver transplant. So we usually take one in the pre and hepatic phase, another one in an hepatic phase, after reperfusion, and at the ICU after we finished. As you know, each one of these phases got very particular hemostatic features that difference one to the other, and for them we have to face as anesthesiologists and to be prepared and controlled. This is the adapted treatment algorithm that we use in the liver transplantation, and as I mentioned before, the cartridge now is sort of different. We are not using in this cartridge heparinase because the heparin doesn't play an important role in this sort of surgery. But what is important in this surgery and other surgeries such as polytrauma is the fibrinolysis, and that's why we need to assess the fibrinolysis. How we do it? With this new dial here that appear in the main screen. Yeah? So, I'm not going, because we are running out of time, I'm not gonna go through this whole case in liver transplant. You can see it online because it was published a few weeks ago, but what is important is that we follow the protocol of sampling, as I said before, during the OR, during these three Quantra tests during each one of them. We follow the goal-directed treatment algorithm to treat that patient during that surgery, and the importance of the fibrinolysis marked here. For those who likes curves, we also got curves, and we also have in another screen the trends of how the patient is doing. So, the take-home message could be that Quantra third-generation viscoelastic test can offer us a prompt and an accurate diagnosis and treatment, so providing to the patient better medical care, to we, the professional, evidence-based medicine, and to the health center, economic and resource savings. Thank you.
Yeah. Thank you very much, and thank you to both my colleagues who stuck to their time limits. So we've got about 10 minutes for questions. So if anyone would like to ask any questions about these two new technological advances, then please stand up or put your hand up. Yep, go ahead. There's a microphone coming towards you.
Hello, thank you for your presentation, Alex. My name is Fernando, I'm from Chile. Buenas tardes. For you. Spanish, yes. Here in Chile, working at tertiary center, we operate about 2 cardiac surgery per day, about 40 cardiac transplant, 15 pulmonary transplant, and we also have ECMO. We have a protocol based on ROTEM, Delta ROTEM, and we use it for post-cardio surgery, coagulopathy, and also for replacement of factors at ECMO or at BAD. In your experience, do you notice or do you have notice any difference between ROTEM, we have a Delta ROTEM, and Quantra that you use in your protocols? Thank you very much.
Right. Thank you for your question. It is interesting, but the thing is that that we previously used ROTEM in our center, but the device got a lot of problems. So we during the time we were having the correct cartridges, the machine was most of the time like with some troubles, and not everyone at my center was familiar to the technology, to interpretation the results. Also, another of the complaints that they used was that the timing to get the result was so long. So getting to know all that situation, we changed, and what we found is that this device is easier to understand for most of the people, and also to teach for the residents, nurses, surgeons, which is important. They have to know, and it's quicker. I would say that it's quicker. I know that there are algorithms that A5, A10, because I know all that, obviously, but this can give you the whole results, and you get confidence of what you're having.
So I would urge you to go and have a look, so you can play with both the new i-SEP Cell Saver and the Quantra over in the stand, and just go and have a look and have a play. It's much more intuitive to use. Even I can understand it. I'm not sure you could teach surgeons, but you know, it's worth a try.
I mean, it's difficult.
Any other questions? Yes.
Felicidades, lo has hecho muy bien. Félicitations, c'est très bien, c'est très clair. Hello, I am a question for you, for Barroso. Yes, in your test, I have Quantra at my hospital. Okay, how, in your opinion, the hypocalcemia, hypothermia, or, for example, another factor influence in this test? Do you think it's necessary to modify the temperature for this question, for this Quantra?
Thank you for the question. I have no data to respond to that. I'm sorry. I mean, my opinion, wouldn't be useful. What do you think?
Maybe we can add that for all viscoelastometric testing, the blood, the citrated whole blood, is put back at the 37 degrees and not and is recalcified in the device. So the viscoelastometric testing doesn't see hypocalcemia or hypothermia. So you can have a patient bleeding from hypothermia and hypocalcemia clinically with that viscoelastometric testing normal. Is it clear?
Yes.
Clear.
In other words, it shouldn't be a problem. You still have to treat the calcium clinically and the temperature, but it shouldn't affect your point of care testing. You can still do it. Any other questions? Good. Well, thank you very much for your attention. Thank you to
Thank you.
Alexandra and Alexandra. And enjoy the rest of your day.